Welcome to the Deep Dive, where we take the most complex systemic issues facing the world today and distill them into knowledge you can actually use. Today, we are undertaking a truly massive task. We're zooming out, way out, past the individual, past the hospital bed, and we're focusing on the collective health of entire populations.
Yeah, we're decoding population health in this immense thing called the global burden of disease.
And it's a topic that, it fundamentally shifts our understanding of what makes us sick, what keeps us alive, and maybe most importantly, who is responsible for all of it. So our mission briefing today is to unpack this central idea of collective responsibility.
Right.
We're synthesizing sources that explore the mechanics of, how we even measure health globally, tracking the rapid rise of these new chronic threats.
And looking at some really surprising methods, genetics, machine learning, that are being used to understand the true causes of disease.
So to start, we probably need a clear definition of what we're even talking about here. What is public health?
Well, the best place to start is the definition from the UK Faculty of Public Health. They define it as the science and art of promoting and protecting health and well-being through the organized efforts of society.
That phrase, organized efforts of society, that feels absolutely crucial.
It is, because it explicitly moves the focus away from just, telling people to eat better or exercise more. It's about systemic influence.
It's the system, not just the individual.
Exactly. Population health looks at the health outcomes of an entire group, and critically, it examines how those outcomes are distributed within that group.
So why do some people suffer more than others?
Precisely. And answering that requires partnership between government, health services, city planners, educators, everyone.
And what we want to deliver to you, the learner, today is that aha moment, that moment that proves this systemic view is necessary. We're going to show you how your health isn't just determined by your doctor or your diet, but by this complex, nested structure we call the hierarchy of systems.
A structure that spans everything, from your individual molecules right up to global ecology and climate. It's huge.
And to manage health at that vast systemic level, you need a way to measure it, a global scorecard.
You can't solve a problem if you can't accurately define its scale. And that brings us to the global burden of disease exercise, or GBD.
The GBD, this isn't just a spreadsheet, right? This sounds like one of the great undertakings of modern health informatics.
Oh, it is. It was initiated by the World Bank way back in 1992.
1992. So it's been going for a while.
A long while. And the core objective was to produce consistent, reliable estimates of disease burden for all diseases, all injuries, all risk factors all over the world.
Because before that, the data was what? Patchy.
Very patchy, incomparable.
Yeah.
Mostly just focused on mortality, on what kills people. The GBD's goal was to give policymakers evidence for priority setting, moving beyond that.
So not just what kills us, but what causes widespread suffering and long-term disability. And the key metric they introduce, the one that lets us finally compare the impact of, say, a fatal heart attack against something chronic like depression or crippling back pain, that's the DALY, the disability-adjusted life year.
The DALY is arguably the most revolutionary metric in public health planning of the last 30 years. It's a brilliant fusion of two core concepts.
Okay, break it down for us. What are the two parts?
First, you have the years of life lost, or YLL. That measures premature mortality, compares the actual age of death against a standardized expected life expectancy.
So if a child dies from an infection, that contributes a massive YLL score.
A huge score. But the second part is what truly changed the game. It forced health systems to look beyond their morgues and emergency rooms. It's the years of life lived with disability, or YLD.
The YLD.
Precisely. This part accounts for the time a person spends living with a disease or injury, and it's weighted by the severity of the disability. This is where that holistic view comes in.
So a fatal cancer would contribute heavily to YLL. But something like severe lifelong depression or chronic migraines, conditions that rarely kill but just destroy your quality of life, those contribute heavily to YLD.
Exactly.
Okay.
So the DALY captures that total burden. It mandates that a condition that causes 20 years of severe disability counts almost as much to the overall burden as a condition that causes 20 years of premature death.
And that recognition is so critical because historically those non-fatal conditions were they were completely underprioritized.
Massively underprioritized. The DALY is the policy lever. It gives you the evidence to make better decisions.
Okay, so let's jump into section 1 and look at the actual score on this global scorecard. How has the landscape of global disease dramatically shifted? First, the headline news is, well, it's overwhelmingly positive. We are living much, much longer.
We are. Global life expectancy at birth climbed significantly, rising from about 61.7 years in 1980 to 73.0 years in 2017.
That is a consistent decades-long trend of adding about zero point 0.3 years to the global average every single year.
It's an astonishing collective achievement. It's like adding a day of life every 10 days globally for 40 years.
And what's the main driver behind that?
The primary driver has been a substantial fall in child mortality, largely thanks to tackling common infections through better sanitation, nutrition, and crucially, immunization.
But this incredible gain in longevity, it comes with a cost, a complexity.
That's right. This gain is partially offset by the rise in mortality from conditions that afflict adults. Things like diabetes, chronic kidney disease, cardiovascular illnesses that occur later in life.
Right.
And we have to acknowledge, while the global trend is positive, some areas haven't seen these increases, particularly for men in regions hit by conflict or severe inequality.
Which brings us to what the sources call the demographic challenge, this paradox of the numbers that every health system is grappling with. It says here that age-standardized death rates for most diseases are actually falling globally. We're generally better at treating things.
We are, across the board.
But despite that, the total numbers of deaths from many of these diseases are rising. That sounds like a contradiction. How does that work?
It's a fascinating reflection of our own success, really, and the burden that comes with it. There are two fundamental intertwined reasons.
Okay.
First, simple global population growth. There are just billions more people now than there were in 1990.
More people, more disease. Makes sense.
But the second and more profound reason is the shift in the age structure of the population, what we call the inverted population pyramid.
Meaning we have more older people.
Far more. Because of those successes in child survival, we have way more people surviving into their 70s, 80s, and 90s.
So if you have this massive swelling population of older individuals, even if the treatment for their typical illnesses is slightly better than it was 30 years ago.
The sheer volume means the total number of heart attacks, strokes, and cancer diagnoses just explodes.
I see. So we're treating more total cases, even if we're treating each case a bit more effectively.
Exactly. And the total burden on health systems just keeps increasing. And for a few specific conditions, HIV, AIDS, diabetes, chronic kidney disease, the age-standardized death rates are still rising, defying that general trend.
This demographic reality, it really defines modern global health, this great transition from infectious killers to these chronic long-term conditions.
Yes, the rise of non-communicable diseases, or NCDs.
The numbers are pretty stark, aren't they?
They are. Looking at the GBD data from 2019, communicable, maternal, neonatal, and nutritional causes, all that stuff accounted for only about 1/4 of global deaths.
And that's down from roughly 1/3 in 1990.
Exactly. That category is receding thanks to huge coordinated efforts.
And in its place.
NCDs now dominate. They account for about 2/3 of all global deaths. The top fatality causes in 2019 confirm this completely.
What are they?
Number 1, cardiovascular disease, claiming 18.5 million lives. Number 2, neoplasms, or cancer, claiming 10 million. And number 3, chronic respiratory diseases. These are the giants we face today.
That is a fundamental reengineering of the human health threat profile in less than 3 decades.
And this rapid change isn't uniform. We have to apply that critical lens of regional variation.
Right.
So while the overall global picture is dominated by NCDs, those communicable maternal and neonatal causes, they still account for about 2/3 of premature mortality in places like sub-Saharan Africa.
Wow, so it's a completely different world.
Completely. And this is what makes global health policy so challenging. The solutions you need in, say, Oslo, where the concern is managing aging populations with chronic kidney disease, are entirely different from the solutions needed in rural sub-Saharan Africa, where the focus is still on making sure children survive their first 5 years.
The global burden is very unevenly distributed.
Highly.
So let's pivot back to that revolutionary metric, the DALY, and focus on the DB disability, this unseen burden.
Yes, the years of life lived with disability, or YLD. The GBD data forces conditions that historically got minimal policy attention right into the foreground, simply because they caused decades of cumulative pain and suffering. When you rank diseases purely based on YLD in 2019, the list is radically different from the causes of death.
And what's at the top of that list? What causes the most disability?
What stands out immediately? Musculoskeletal disorders ranks number 1.
Musculoskeletal? You mean like back pain.
Exactly. Chronic conditions like low back pain, neck pain, and arthritis. Things that make simple daily life excruciating. They are the leading cause of years lost to suffering.
That is astonishing for something we often just dismiss as a sore back.
It is. Number 2 is mental disorders, depression, anxiety, and so on. Number 3 is other NCDs. Neurological disorders are number 4, and sense organ diseases like vision and hearing loss are number 5.
It's striking that heart disease and cancer are the top killers. They drop way down that disability list.
They do. And by forcing policy focus onto this disability list, the DALY metric achieves its primary goal.
Which
Conditions like low back pain, severe depression, and chronic asthma suddenly receive greater health policy priority and funding because we are finally measuring their true impact on human functionality and quality of life, not just death rates.
So the focus is shifting to keeping people functional and productive for longer, not just alive.
That is the key insight for any health planner. If we can find effective, scalable ways to alleviate the massive systemic burden of chronic pain or severe depression, the societal, economic, and human benefit is immense.
And the daily is what gives us the evidence to justify that shift.
It is.
That realization that health is fundamentally a product of systemic functionality perfectly sets us up for Section 2. We need to move from describing what the burden is to understanding what causes it and going way beyond just, individual poor choices.
We have to accept that health is a highly complex interaction between a person's genetic background and their environment.
And when we say environment, we mean everything, right?
Everything. The physical, the biological, the built environment, our cities and transportation, the social environment, so jobs, income, education, and critically, the entire global ecosystem.
It's a lot to juggle. So how do we make sense of that complexity?
We use the hierarchy of systems model. It's a tool for thinking. It helps us understand that influences on health exist at every possible level, from the smallest molecular scale to the largest geopolitical scale.
Okay, let's make that concrete. The source material uses the example of ischemic heart disease. Let's trace its causes through every level of that hierarchy.
Great example.
Let's start at the bottom, the absolute fundamental level, the molecular level.
Right. So at this level, you might find something like an APOB gene mutation causing familial hypercholesterolemia.
So a genetic factor, it predisposes you to high cholesterol no matter what you eat.
Exactly. Now, move up slightly. At the cellular and tissue levels, that molecular issue leads to foam cells accumulating in the vessel wall, which eventually becomes atheroma, hardening of the arteries.
And then at the organ level?
That's where you get thrombosis of the coronary artery, leading to ischemia and infarction of the myocardium, the heart attack itself.
Okay, so that's all happening inside the body. Now let's shift outside into the person's immediate world, the person-family level.
This is where the classic factors come into play. Limited exercise, a poor diet high in saturated fat, exposure to passive smoking in the home.
This stuff we usually focus on in medical advice.
Usually. But we need to go wider. To the community population level, what matters here?
The world around them.
Yes. The prevalence of obesity in that community, the lack of sidewalks or safe green spaces, the availability and cost of shops that sell fresh produce versus cheap, energy-rich processed foods. If you live in a food desert, that is a direct environmental determinant of health.
And finally, the highest levels, society and ecology.
Here you're talking about broad governmental policies on tobacco taxation, the existence and funding of cardiac screening programs, and even global agricultural policy that influences the fat content in the dairy and meat we eat worldwide.
Wow. So what this framework immediately clarifies, and this feels like the most important takeaway, is that healthcare is usually not the major determinant of health status in a population.
It really isn't. If we only intervene at the organ level, giving a stent or bypass surgery, we ignore the policy, the community, and the molecular inputs that caused the problem in the first place.
It shows why we have to have this global health consciousness,
Yeah.
recognizing that what's in your local supermarket might be determined by worldwide economic subsidies for certain crops. And that is a health determinant just as much as your own genes.
And those determinants don't just appear in middle age. They operate over the whole lifespan. This is the life course perspective.
So they accumulate over time.
They do.
Yeah.
We often focus on behaviors acquired during childhood and adolescent smoking, drinking, which profoundly influence adult disease risk. But interventions need to start even earlier.
Much earlier. The source material points to compelling evidence that influences operate even before birth.
Yes. Low birth weight, often linked to undernutrition during gestation, can permanently program cardiovascular and metabolic responses.
Program them. What does that mean?
It's a form of early developmental stress response. That nutritional deficit in the womb, years before the child can make any lifestyle choices, can lead to a permanently increased risk of hypertension, type 2 diabetes, and heart disease in adulthood.
Because the body is designed for scarcity, but then it encounters abundance.
Exactly. The design backfires. So successful prevention has to be complex. It requires not just educating adults, but early, even prenatal intervention, and multiple actions across that whole hierarchy of systems.
And if we aren't intervening successfully at the population level, those risk factors are just going to mount.
Right. Let's look at the GBD's analysis of what specific risk factors are driving the burden now in 2019 compared to 1990.
The sources highlight a really serious paradox here. Socio-demographic development is progressing: more wealth, better education, better sanitation globally.
But the gaps in health outcomes are actually widening fastest in countries that already have the highest development index.
So wealth isn't fixing it.
It suggests that advanced development introduces new risks faster than it solves the old ones, and the benefits of that development are accruing unequally.
And the GBD exercise specifically pointed out a major policy failure here.
It did. That public health efforts are not giving sufficient priority to important global risk factors that are increasing over time.
Let's look at the top 5. What were the biggest risks in 2019, and how much have they climbed since 1990?
Number 1 is high blood pressure. It was ranked 7th back in 1990.
Wow, a big jump.
A huge jump. Number 2 is smoking and secondhand smoke exposure, which was 5th. Number 3 is high fasting blood glucose, which was way down at 11th.
From 11th to 3rd, that's huge.
And number 4 is low birth weight and short gestation, which remains stubbornly high. But critically, number 5 is high BMI, high body mass index.
And where was that in 1990?
It was ranked a relatively minor 16th, and it has leaped into the top 5.
So, high BMI from 16th to 5th, and high blood glucose from 11th to 3rd. That is a stunningly fast shift toward these chronic metabolic and lifestyle-related risks.
It is. And if you look further down the list, ambient particulate matter pollution also jumped from 13th to 7th. These are the modern growing threats. The challenge is clear. Health systems have to transform their focus to respond.
And right now, the data suggests we are losing the battle against these systemic risk factors.
That's what it suggests.
Okay, let's delve into a few of these major risks to see why this systemic failure is happening. Let's start with smoking, still one of the top 3.
The health effects are, enormous and well known.
Mhm.
A majority of lung cancer and COPD cases, major cause of heart disease. But it's the way the system works that makes it so sticky.
That complex hierarchy in action again.
Absolutely. At the molecular level, nicotine acts on the nervous system to create dependence. But sociologically, the motivation to start is often linked to identity.
Yeah.
A young person might smoke to stay thin or look cool.
And that's magnified by the societal environment.
Massively. By the tobacco industry's huge historical advertising and lobbying budget, which just dwarfs health services' anti-smoking campaigns.
We do know what works, though, at least in high-income countries.
We do. Increased taxation, banning advertising, banning smoking in public places, providing support for cessation. These top-down policies have helped drive down rates.
But the global challenge is relentless.
Yes, smoking rates are still high in poorer areas, and they are rising among young women and in low-income countries where tobacco companies are aggressively finding new markets.
Okay, next up, obesity. That dramatic jump in high BMI ranking means we are experiencing systemic weight gain.
We are. In the UK, the weight distribution of the entire adult population has shifted upwards. It translates to about a 1 kilogram average increase in weight per adult per year. That is a collective population-level phenomenon.
And we absolutely cannot explain this simply by poor individual choice.
No, this requires a systemic explanation. We have to look at the obesogenic environment, a system fundamentally designed to encourage people to eat more and exercise less.
What does that look like in practice?
Well, think about the interplay of environment and economics. We have high availability of cheap, heavily marketed, highly processed, energy-rich foods that drive hyperconsumption.
Right.
Then you have the built environment. The increase in labor-saving devices, from remote controls to ride-sharing, the increase in passive transport. If cities aren't safe or convenient for walking and cycling, people drive.
So the entire system, from food subsidies to urban planning, is pushing weight gain.
It is. So the solution can't be just individual dieting. It requires strategies that fundamentally reverse that obesogenic environment.
We see a similar systemic paradox when we look at poverty and affluence.
Yes, the double burden. It's a truly cruel situation that many countries face.
What is the double burden?
It's having large populations still stuck in poverty, suffering from classic issues like diarrhea and malnutrition, often in rural or slum areas.
While at the same time,
At the same time, you have affluent populations, often in urban centers, who are suffering from the chronic illnesses of excessive wealth, type 2 diabetes, heart disease, hypertension.
it's a health disaster on two tracks simultaneously.
Exactly. And it requires two completely different sets of public health interventions. And even in sustained high-income countries, affluence has its own adverse health consequences.
Like what?
Despite economic growth, that growth hasn't solved deep problems like inequality, chronic stress, congestion, and the pervasive rise of mental health problems. Economic growth alone is not the cure.
And finally, we have to address the ultimate environmental determinants: pollution and climate change.
Truly societal risks that require global action, starting with atmospheric pollution.
We're talking emissions from industry, power plants, motor vehicles.
Yes, sulfur oxides, nitrogen oxides, fine respirable particles. They're severely polluting cities across Asia, Africa, Latin America, and Eastern Europe.
And this directly translates to increased death rates from respiratory and cardiovascular disease.
It does. And we often forget that low-income countries face a high rate of respiratory disease from indoor pollution, from heating and cooking with low-grade fuels like biomass,
And then there is the elephant in the room.
carbon dioxide, and global warming. The sources call this, and I quote, arguably the world's most important environmental health issue.
The health impacts are profound.
Yes, we're talking altered rainfall patterns, rising sea levels, rising global temperatures. We see changes in the geographical range of vector-borne infectious diseases, mosquitoes carrying dengue or malaria appearing in new areas,
And the direct effects of extreme weather: more floods, more droughts.
claiming millions of lives, creating millions of environmental refugees, which in turn leads to huge economic costs and resource scarcity.
And yet, despite this profound and immediate public health threat, we are stuck.
That is the ultimate systemic failure. Politicians globally cannot agree on an effective framework of actions, while the industrialized world continues with lifestyles that are simply unsustainable.
It's the biggest failure of modern public health governance.
Arguably, yes.
That transition from understanding the causes to managing the population, it sets us up perfectly for Section 3, the tools of population management. If we understand the risks, how do we intervene collectively? Let's start with screening.
Screening is a proactive measure. You're applying a test to a large number of asymptomatic people with the goal of reducing morbidity or mortality.
It sounds simple, but the practice is highly complex and risky if not managed properly.
Very risky. And screening must meet very strict criteria to be implemented responsibly. These are the famous Wilson and Junger criteria from the WHO. They're an essential checklist.
Okay, what's on the list?
4 essential requirements. 1, is the disease an important public health problem? Is the frequency and severity high enough to even warrant mass testing?
Okay, is it worth the effort?
Exactly. 2, is there a suitable screening test? And suitable means cheap, acceptable to the population, easy to administer, safe, and scientifically valid.
So it's not just about the science, it's about logistics and cost.
Absolutely. 3, is there a recognizable latent or early stage? If the disease progresses too quickly, screening is pointless.
And 4,
Is there effective treatment for the disease at that early stage that demonstrably improves prognosis? If you detect it earlier but the patient dies at the same time, all you've done is worry them for longer.
so it's not enough to simply have a test. You must prove the entire program actually works.
Right, which is why screening programs must always be rigorously evaluated in trials. And those trials are prone to several crucial biases that can make a program look more successful than it actually is.
What are the main biases?
The 3 major ones are self-selection bias, length bias, and lead time bias. Let's start with lead time bias, which is the most common pitfall.
Okay.
Lead time bias occurs because screening detects the disease earlier. So if a person would have lived from age 60 to 70 without screening, but screening detects the condition at age 58, it looks like this screening extended their life by 2 years, even if they still die at age 70.
So their survival appears longer on the chart, but their actual lifespan is unchanged. That's a crucial distinction.
It is. Then there is length bias. Screening is more likely to catch slowly progressing, less deadly forms of a disease because the patient lives in that detectable asymptomatic state for longer.
So you're catching the lap dogs of cancer, not the wolves.
A very good way of putting it. So your treatment success rate looks much better than it really is.
And we have to acknowledge the dark side of screening. Overdiagnosis.
Overdiagnosis is the definitive problem. It's treating a disease that would never have progressed to cause harm in the patient's lifetime.
Like some slow-growing prostate cancers.
Exactly. They'll never cause symptoms, but if detected, they often lead to aggressive treatment with serious side effects, offering zero benefit to the patient.
And beyond that, there's the risk of false reassurance if a test is negative and the diversion of resources from other, more cost-effective measures.
It has to be continually justified by the evidence.
Moving from detection to defense, let's look at immunization, the quintessential example of the organized efforts of society.
We differentiate between passive and active immunity. Passive immunity is directly injecting antibodies. It provides immediate but short-term protection.
An example.
The monoclonal antibody palivizumab, used against RSV infection in premature infants to prevent severe lung disease.
And active immunity.
That's what most people think of as vaccination. Administering a vaccine that invokes the body's own antibody response, leading to longer-term memory and protection.
But the real power of immunization is its indirect effects, the collective protection.
The most famous indirect effect is herd immunity. By achieving high vaccination coverage in a population, you alter the disease transmission chain, thereby protecting the vulnerable who can't be vaccinated themselves.
And another often overlooked benefit
Is the reduction of antibiotic resistance. For example, vaccinating against certain pneumococcal serogroups can selectively reduce the prevalence of those bacteria that are commonly associated with antibiotic resistance. It's a massive upstream public health benefit.
And we have the historical success stories that prove the case.
The eradication of smallpox, one of humanity's greatest scientific triumphs, and the ongoing painstaking polio eradication program. These are the moments when public health shines.
Now, let's talk about the acute crises, managing epidemics and pandemics. We need to start with the definitions.
Yes. An epidemic occurs when cases of an illness in a community or region are clearly in excess of normal expectancy. An outbreak is just an informal term for a small, localized epidemic.
And pandemics.
Pandemics are the rare, catastrophic events. They happen when a novel agent like SARS-CoV-2 or a new strain of flu spreads beyond international borders, affecting multiple countries.
And epidemics often arise when preventative measures break down.
Exactly. Breaches in food safety, failure to maintain industrial cooling towers causing Legionella, or, critically, falls in vaccination coverage, leading to measles epidemics.
So how do you detect these things early?
Public health agencies rely on sophisticated surveillance. The continuous collection and analysis of cases from statutory notifications or electronic health systems. The challenge is distinguishing a true epidemic signal from mere sporadic cases, especially in the early stages.
And when an epidemic is confirmed?
An incident management team, or IMT, takes over. They follow a very structured process, establishing a case definition, rapid contact tracing, testing potential sources.
And implementing control measures.
Right, which could be anything from isolating infected individuals to temporarily closing a business.
And management hinges on the epidemic curve.
That curve is the IMT's roadmap. It tracks new cases over time. In person-to-person spread epidemics, it's used to estimate key stats, like the basic reproduction number, R0, and to make projections about the peak and duration of the event.
And pandemics pose unique challenges that go beyond just scale.
They're rare, so agencies have little direct recent experience, and more importantly, they pose existential risks to society-wide infrastructure. The supply chain, schools, finance, transport way beyond just healthcare facilities.
Which necessitates massive preemptive planning and tabletop simulations.
Exactly, so that the next time, the global response isn't caught flat-footed.
Now we transition into Section 4, moving from managing populations to the fundamental science of cause and effect. Epidemiology. How do we actually measure disease in a population?
Epidemiologists are the detectives. We use specific metrics to count the disease pool and the flow of new cases.
Let's start with prevalence.
Prevalence is a proportion, a snapshot. It's the total number of people with a longer-term condition at a specified time, divided by the number of people at risk.
Yeah.
So if we say the prevalence of diabetes among people aged 80 and over is around 10%, that means 1 out of 10 people currently has the condition.
And then we have incidence, which is about new events.
Right. Incidence is expressed using the incidence rate. And this is where the metric gets tricky, but highly accurate. It's calculated using a denominator called person time.
Okay, break down person time for us, because this is where people can get lost. If you have 100 new cases in a year in a population of 1,000, Why is the incidence rate actually calculated as 105 per 1,000 person years, not 100?
It's because we must only count the time that people were at risk of getting the disease.
Yeah.
Once you have the disease, you can't get it for the first time again, so you stop contributing time to the denominator.
Ah, see.
Think of it this way. If we observe 1,000 people for a full year, that's 1,000 person years of risk. But if 100 of those people develop the disease halfway through the year, we have to subtract the 6 months of observation time for those 100 people. You're removing the risk time they no longer contributed.
So the denominator gets a little smaller and the rate gets a little higher. It's more accurate.
Exactly. It reflects the true speed at which new disease is appearing in the remaining susceptible population.
But this all sounds straightforward until you try to establish causation.
Correct. Epidemiology is inherently difficult. It's much harder than lab science, where you can control everything. We can't ethically randomize people to harmful exposures like smoking. This leads to the monumental challenge of causal inference.
The problem of confounding.
The biggest problem, where the relationship between an exposure and an outcome is confused by some other causal factor.
What's the classic example?
Coffee and lung cancer. Coffee consumption may appear strongly associated with lung cancer because, in the general population, smoking is much more common among heavy coffee drinkers.
So smoking confounds the association. If you didn't account for smoking, you might wrongly conclude coffee causes cancer.
Precisely. To tackle this, we have distinct study designs. The clinical trial is the gold standard, where you randomly allocate people to an intervention. But you can't use trials for harmful exposures.
So for that, you need observational studies.
Yes. We rely on cohort studies, like the Framingham study, where you track a large population forward in time, and case control studies, which look backward. They enroll cases with a disease and controls without it, and compare their past exposures.
Like the studies that proved smoking caused lung cancer.
Exactly. It was that careful, collective weighing up of evidence from multiple designs over time that settled the science.
However, we now live in the age of big data and genetics, and there's a powerful shortcut to causality.
There is a modern tool called Mendelian randomization.
Mendelian randomization, or MRBE. Okay, that sounds intense. Break that down for us.
It's actually a really clever idea. It's used to study whether the relationship between a modifiable risk factor, like high LDL cholesterol, is truly causal. And it does this using genetic variation.
How?
It uses genetic variants that influence the level of that risk factor as a kind of instrumental variable. And here is the magic. Since our genes are randomly allocated at conception, this random allocation of alleles naturally mimics the random allocation found in a clinical trial.
It's like a natural experiment.
Exactly. If a specific genetic mutation happens to lower a person's LDL cholesterol their entire life, comparing the heart health of people born with that mutation versus those born without it is like running a decades-long randomized trial on cholesterol lowering, but using readily available observational data.
It sounds incredibly powerful. It uses observational data to test a causal relationship.
It does. It can confirm results from expensive clinical trials or, just as importantly, redirect research away from non-causal relationships that were only showing up because of confounding.
But this requires massive statistical power, right? Massive databases.
Absolutely. It needs huge sample sizes, which is why the proliferation of large databases like the UK Biobank is essential. It's an approach built on the back of the genomics revolution.
And it's not without its own specific challenges, something called pleiotropy.
Yes, that's the main issue. Pleiotropy means a genetic variant might have more than one effect. For instance, the variant that lowers your LDL might also slightly influence your blood pressure.
So if it influences two things, how do you know which one caused the final outcome?
Exactly. It makes the link ambiguous. So researchers must use multiple analytic methods and rigorous consistency checks to make sure the conclusion really holds up.
Finally, let's wrap up by discussing the crucial role of health data and informatics in making all of this possible.
We have a long tradition here, starting with the legal requirement to register births and deaths, including the cause of death, often using the International Classification of Diseases, or ICD-10.
But the sources stress that making this data useful across time and place requires immense standardization.
You need 5 crucial factors: standard terminologies, similar disease definitions, access to diagnostic skills globally, standard protocols for coding, and robust quality control. It's extremely complex.
And now the data world is changing rapidly. We're shifting away from only using highly structured data.
Right, toward using less structured data from clinical IT systems, electronic patient records, drug dispensing databases, radiological software. This messy real-world data requires innovative informatics solutions to turn noise into signal.
And how do we do that?
Two main approaches. One is developing comprehensive standard classification systems, like SNOMED DCT, a highly standardized multilingual vocabulary designed for electronic health records,
And the alternative?
is applying cutting-edge statistical methods to the data as it is, using natural language processing to cull diagnoses from free text notes written by doctors or employing machine learning algorithms. These approaches are suited to large, messy data sets where the cost of complete human systematization would be prohibitive.
What an extensive deep dive. We've covered everything from a single molecule to global policy. Let's do a rapid-fire recap of the most important concepts.
We started by establishing public health as a collective societal effort. We introduced the GBD exercise and the revolutionary DALY metric, which finally gives serious policy weight to disability from conditions like depression and back pain.
Right, forcing a focus on function, not just fatality. We then explored the dramatic shift in the global landscape, the great transition where non-communicable diseases, NCDs, now account for 2/3 of deaths.
A shift driven by massive systemic increases in risk factors like high BMI, high blood pressure, and high fasting glucose.
The hierarchy of systems model showed us exactly why healthcare is rarely the major determinant of health status, proving that causes range from molecular ApoB mutations all the way up to global agricultural and climate policies.
And we looked at the rigor required to identify true causes, moving from the difficulty of overcoming confounding in traditional epidemiology to the statistical power of Mendelian randomization.
Which uses genetic variation to mimic randomized trials and establish causality.
Ultimately, improving health requires collective efforts focused on population-level risks and intervening early across the life course.
Which leaves us with a final provocative thought for you, the learner, to consider as you step back into your world. We've established that the health of a population is sustained by interventions spanning enormous complexity, from developing standard medical classification systems like SNOMED DCT to implementing international agreements on pollution.
We have seen that the major drivers of premature death and chronic illness, high BMI, blood pressure, ambient pollution, are systemic environmental problems that are currently increasing globally. And we know that healthcare itself is usually not the primary determinant of population health status.
So if health is determined by influences that span from a single ApoB mutation to the stability of the global climate, what responsibility does an individual truly hold, and where is their agency best applied? Given the evidence that society's organized efforts are the most powerful levers for health change, where do you find your power to drive that change? That is the question we leave you with today.
Thank you for joining the deep dive.
Until next time.